Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 341 of our pharmacotherapy series, which majors in the interpretation of clinical laboratory tests. My first question to you reads, a 24-hour creatinine clearance determination was ordered for patient DBS, a 72-year-old, 62 kg white man. The following data were returned from the clinical laboratory. The total collection time was 24 hours. His total urine volume was 1,000 milliliters. He had a urine creatinine concentration of 42 milligrams per deciliter. His serum creatinine was 2 milligrams per deciliter. I would like you to determine both the measured and the estimated creatinine clearance for patient DBS based on the given data, and compare and contrast these results. Using equations commonly quoted in literature, DBS has a 24-hour measured creatinine clearance of approximately 15 milliliters per minute. His estimated creatinine clearance is 29.2 milliliters per minute using the Cockcroft-Gault method. Based on both methods, DBS's ability to clear renally eliminated drugs is impaired, and adjustments to the dose or frequency of drug administration will need to be made. An incomplete collection of urine during the 24-hour period or possible mishandling of the specimen can be explanations for the lower value seen with the measured creatinine clearance. Because DBS had an elevated serum creatinine of 2.0 mg per deciliter, the accuracy of the Cockcroft-Gault estimation might also be compromised. DBS's baseline serum creatinine will need to be established, and if it is determined that serum creatinine of 2.0 mg per deciliter is corresponding with DBS's baseline, then Cockcroft-Gault estimation will hold true. If serum creatinine of 2.0 mg per deciliter represents an acute change, then Cockcroft-Gault equation should not be used to estimate renal function in DBS. We will now progress to the next case, which reads, TCL, a 68-year-old man, visits his primary care provider to assess control of his type 2 diabetes mellitus. His average blood sugar over the past 90 days recorded by his blood glucose monitor is 195 mg per deciliter. However, TCL's hemoglobin A1c is 9%, which correlates with an estimated average glucose of 240 mg per deciliter. TCL is confused that these values are different because he routinely ensures his blood glucose machine is calibrated and coded properly. So my question to you is, why is the laboratory average different? TCL should not be alarmed with the difference in these values. His blood glucose monitor is likely working properly and adequately measuring his plasma glucose concentrations. However, the monitor may be reflecting a lower average glucose concentration because of the timing of his daily testing for glucose. For example, measuring blood glucose in a fasting state more frequently than after mealtime could contribute to lower average concentrations because fasting values are typically lower than postprandial concentrations. The A1C is more indicative of his average blood sugar control during the past 90 days than the 90-day average recorded by his blood glucose monitor. The next case reads, PCM is a 61-year-old man admitted status post-fall because of alcohol intoxication. He has no known drug allergies. PCM's past medical history is significant for alcohol-induced seizures, alcohol abuse for a period of 20 years, and hypertension. PCM's laboratory tests revealed the following. His albumin levels were 2.0 grams per deciliter. Calcium levels were 6.8 milligrams per deciliter. His total bilirubin was 10.8 milligrams per deciliter. He had a serum aspartate aminotransferase of 280 units per liter. His alkaline phosphatase was 240 units per liter. So my question to you is, would patient PCM be considered hypercalcemic, and how should he be managed? This case presentation provides insufficient patient data to make a conclusion concerning treatment. However, it does illustrate the importance of treating the patient as a whole, not as a specific laboratory value. Because calcium in the serum is partially bound to plasma proteins, mostly albumin, the serum calcium concentration is affected by the concentration of these plasma proteins. If the albumin concentration is low, the reported serum calcium will generally be less than the lower limit of normal. A useful method to estimate a corrected value for serum calcium in the presence of a low serum albumin is to use the following guideline. The total serum calcium will decrease by 0.8 mg per deciliter for each decrease of 1.0 gram per deciliter in serum albumin concentration. Thus, evaluating PCM's corrected calcium is computed as follows. 4 minus patient's albumin levels multiplied by 0.8 all added to the calcium is equal to the corrected calcium. For PCM, his corrected serum calcium is 8.4 mg per deciliter, which is just below the reference range and probably does not warrant treatment with calcium supplementation unless his serum calcium continues to decline. Direct measurement of ionized calcium is independent of albumin concentration, making it unnecessary to correct calcium concentrations in the presence of hypoalbuminemia. Unfortunately, some clinical laboratories do not have the capability of measuring ionized calcium. The next case reads, KAJ, a 55-year-old man, with a history of stable angina presents to a hospital accident and emergency department. He complains of sudden onset chest pressure and tightness, diaphoresis, and nausea that has been waxing and waning for the last few hours. KAJ describes his discomfort as severe at times and not relieved by position change, antacids, or sublingual nitroglycerin. An electrocardiogram reveals ST segment depressions consistent with myocardial ischemia. His cardiac biomarkers reveal the following: K of 200 international units per liter, creatine kinase myocardial band of 5%, and CTNL of 0.67. KAJ is diagnosed with a myocardial infarction, that is a non-ST segment elevation myocardial infarction, and is admitted for a cardiac catheterization. So my question to you is, Why are the total CK and creatine kinase myocardial band serum concentrations within the reference range, despite clear evidence, including elevated CTNL, supporting an acute myocardial infarction? Although CK and creatine kinase myocardial band are very helpful laboratory values for identifying and assessing myocardial damage or necrosis, the utility of these values alone can be quite limited. Troponin levels are very sensitive and specific to myocardial cell death, and can become positive sooner than CK and creatine kinase myocardial band, and will remain elevated for a much longer time frame. That is up to 10 days. So even if the CK and creatine kinase myocardial band are not elevated, the troponin can pick up even the smallest amount of myocardial cell death. Based on the clinical picture and the elevated troponin, the patient would be classified as having a non-ST segment elevation myocardial infarction. The next case reads, TLH, a 50-year-old female, is hospitalized with a sustained high fever of 39.2 degrees Celsius and severe back pain. The results of the CBC and leukocyte differential are as follows. Total WBC count is 21,000 per microliter. Neutrophils account for 74%. Bands account for 6%. Lymphocytes account for 14.6%. Monocytes account for 8%. Eosinophils account for 1%. Basophils account for 0%. Imaging and other blood work was ordered. TLH is diagnosed with an abscess in her lower back and Staphylococcus aureus bacteremia. So my question to you is, how is TLH's laboratory report consistent with a systemic bacterial infection? WBCs are the host's chief defense system, and the neutrophil is the main component of that system. During bacterial infections, the leukocyte count and the neutrophils are generally increased, and a left shift, that is an increase in bands, may be noticeable. The percentage of other types of WBCs is decreased proportionately, because the number of neutrophils is increased. As the infection progresses, the percentage of band cells may decrease as a result of an increase in the number of neutrophils that have a longer half-life. This decrease in bands does not necessarily indicate improvement. A decrease in the percentage of neutrophils with a decrease in the total WBC count is characteristic of effective antibiotic therapy. The next case reads, the Staphylococcus aureus causing TLH's bacteremia is found to be methicillin sensitive, and she is started on oxacillin 2 million units infused every 4 hours for treatment. After about a week of therapy, TLH develops a fine red rash all over her body, mild lymphadenopathy, low-grade fever, and generalized swelling. The CBC shows a total WBC count of 8,600 per microliter with 11% eosinophils. So my next question to you reads, what is the significance of this eosinophil count? In the clinical setting, absolute leukocyte counts may be used in conjunction with normal reference values. Absolute counts are calculated by multiplying the percentage of each individual cell by the total leukocyte count. Eosinophils are usually increased in allergic reactions. Therefore, a drug-induced hypersensitivity reaction is a strong probability in TLH, with an absolute count of 946 eosinophils per microliter, i.e., calculated as 11% of 8,600 leukocytes. The clinician should be suspicious of an allergic drug reaction when absolute eosinophil counts exceed 300 cells per microliter. Eosinophils may increase before, after, or concurrent with other evidence of allergy, e.g., rash. Eosinophilia without evidence of allergy is not sufficient cause to discontinue a suspected medication unless the eosinophilia is significant, i.e., more than 2,000 cells per microliter. In addition, the absence of eosinophilia certainly does not rule out an allergic diagnosis in a patient exhibiting clear clinical manifestations of an apparent allergic reaction. The next case reads, STP is a 33-year-old female with type 1 diabetes mellitus who presents to the urgent care clinic with a 3-day history of fever, malaise, dysuria, and flank pain. Upon interview, you learn that over the past few days, STP has been unable to keep down any food because of feelings of nausea. Because of this, she has not administered her insulin for 48 hours. Today, her finger stick blood glucose is 415 mg per deciliter, and a stat midstream urinalysis and gram stain indicate the following. The pH is 5.2. Its appearance is cloudy. It has a specific gravity of 1.033. The urine protein is 3+. The urine glucose is 4+. Urine ketones are reported as positive. Urine bacteria is reported as 4+. Urine WBC is reported as too numerous to count, abbreviated as TNTC. Squamous epithelial is reported as few per high power field. Urine nitrite is reported as positive. Gram stain is reported as numerous gram-negative rods. So my question to you is, what objective data from the urinalysis indicate a urinary tract infection? The cloudy appearance of STP's urine indicates the presence of bacteria, protein, and WBCs, which is supported by the urinalysis results. The lack of a significant amount of squamous epithelial cells, the presence of a significant amount of nitrite-producing bacteria, and the gram stain indicate a clean catch urine specimen and a urinary tract infection involving gram-negative organisms, most likely Escherichia coli, that causes a majority of urinary tract infections. My last question to you reads, what objective data from the urinalysis indicate uncontrolled diabetes mellitus? Glucose is normally filtered in the glomerulus and a majority is reabsorbed in the proximal tubule of the kidney. STP's glycosuria, as denoted by the 4+ glucose result, and fingerstick of 415 mg per deciliter indicate the filtered amount of glucose exceeds the capacity for reabsorption, which is approximately 180 mg per deciliter. Additionally, the presence of positive ketones indicates the body is utilizing fat, not glucose, for energy. High levels of ketones can predispose STP to dehydration, resulting in diabetic ketoacidosis. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 342.